Welcome to another edition of Focus on Facebook Live. My name is Hasneen Kermali, Chief Medical Officer here at St. Mary's Hospital in Waterbury, Connecticut. Each month, we like to focus on various clinical aspects here at the hospital and highlight various expertise that we're able to provide to the community in Waterbury. And this month is no exception. I'm joined today by my friend, Chief of Infectious Disease, Dr. Arjet Gega. Thank you very much for taking time out of your busy schedule to join us today.
It's a pleasure.
So today our goal is to learn a little bit about the infectious disease department. Clearly we've gone through a couple of things, well, one big thing over the past few years. But before we get into that, let's talk a little bit about you.
Sure.
You come from Albania, got your medical degree from Turkey, did a little bit of movement along the way before you settled down here in Waterbury. So tell us a little bit about that.
Sure. I was, thank you very much for having me, by the way.
Absolutely.
And I was born in Albania, and the great news is that there is a great Albanian community around here in the Greater Waterbury area.
Yes, there is.
And, I try to be quite active within the community as well. So once I finished my high school, etc., I moved to Turkey in English teaching medical school there, which was a great experience. And then from there, I came to the United States. I did my residency at the University of Florida, which is in the South. And then I moved to Yale for my fellowship. And we stayed in Connecticut because we loved Connecticut. And of course, it's multiple different experiences. You're right about that. And each one of those probably add a different flavor, I think, to a formation as a human being first, and then as a physician.
Yeah.
'Cause even I would say if I compare my experience at the University of Florida with my experience here in Connecticut, they're two different experiences.
Sure.
with different dynamics, etc. I would say that it makes you probably more aware of the situation, makes you more of a global person as well, I think, which is important in infectious disease.
Very, very important in infectious disease. Tell us a little bit about why you chose infectious disease. I mean, to me, going in internal medicine, infectious disease was one of those, wow, this is pretty cool. But then very quickly you recognize there's a breadth of information that you need to understand and keep in mind. What drew you to infectious disease in your path?
So, obviously when a physician, he or she chooses the path, a lot of different factors play a role. Life experiences, mentors, background, etc. But I remember during my residency that when I did that infectious disease rotation, and yes, there is a wow effect. There is, you walk around the hospital feeling the smartest person there is,
Sure.
And as I said, it has a wide scope, and it's always you have to be you have to follow the situation, you have to follow what's happening in the world. There is always different treatments, different diseases out there. Some of them are present in the United States, some of them are not, but are more of a global issue. So when you get an exposure to all these different entities, different diseases, different microbials, I think it fit my character, it fit my the way what I wanted to get out of my career, who I wanted to help. It felt that it was a great opportunity to really help those in need. Because a lot of infectious diseases in the United States and in the world happen to those of us who are less fortunate. And gave me the opportunity to really be helpful, really, to fulfill my mission.
And that brings us to sort of your philosophy in medicine. Clearly, infectious disease is very different from other practices in terms of you really need to hone in on the patient themselves to try to understand the circumstances around what was initiating their problem.
Correct.
To get to that pathway to understand, okay, this is how we're going to treat. And you really try to seemingly avoid necessarily using what I refer to as, the big guns when it comes to your treatment pathway, and really try to hone in on what's going to be helpful for that patient. So what's your philosophy when it comes to managing patients?
Yeah, I mean, obviously it's patients first.
Yeah.
And
great.
that is extremely important, as I said, especially when you deal with certain diseases that happen more likely to the less fortunate and to the patients who have more socioeconomical problems. At the same time, as you know, what we do in the hospital, where most of our time really is spent, is serving the role of a consultant, of a consultant physician, which means that your primary medical or surgical team who is taking care of you in the hospital has an important infectious disease related question that they pose to us, and sometimes is a diagnostic dilemma, sometimes is a treatment dilemma, and sometimes it's both. And basically our role is to really provide the best intervention in terms of not only antimicrobials, antibiotics and similar, but also other interventions like source control, other interventions like preventive medicine measures, etc. And I mean, in infectious diseases, probably people from public believe that all what we do is actually use antibiotics and kill bacteria and microbes. Really what we do in the hospital very often is we actually stop
antibiotics.
Stopping antibiotics is actually probably the act that requires even more expertise and requires also more courage. So I think that a lot of our job in the hospital ends up being really stopping antibiotics or molding the treatment to something that's very, very specific and pinpoint for the problem that the patient has.
Yeah, and it's amazing when we think about the recent pandemic with COVID-19 that we went through. Clearly the role of the infectious disease specialist, not only from a treatment and a diagnosis and a management perspective, but also from an educational perspective, became key in terms of keeping us up to date on what the changes were going on. But at the same time, we were still managing some other challenges here in the hospital with the pneumonias that would happen and the other infections that would take place. And your role was critical in all of those pieces. It wasn't just related to simply the pandemic. There were still other pieces of the puzzle going on.
Absolutely. So of course our role in the hospital also includes infection prevention, also includes management of like infection preparedness as well, and management of that. And when the COVID-19 pandemic hit early 2020, as we were talking before, so none of us were really very well versed about what this virus was and was this pandemic it really will cause to the to the world and also to our microcosmos here in Waterbury and St. Mary's. But I mean, I remember, and we talked about this with some residents about a week ago, and they said, Dr. Gega, we remember we were in intensive care unit and a relatively young patient was about to die because of COVID-19, and we were all terrified, but you were really, calm, and you reassured us, and you told us that, oh, don't worry, you will live to tell the stories of COVID-19, etc. How did you know? And how could you be so cool with it? I said, I wasn't. I was actually probably as terrified as you were. But that's my role, right? That's my training, and probably that's what happened. Is our training, I think, kicked in, and our role was really to prepare the hospital, to prepare the city, because there were some initiatives with the city of Waterbury as well, and to really try to manage this to the best of our capabilities. Of course, we had testing challenges, we had treatment challenges at the beginning, we even had like protection challenges with PPEs, etc. as a country, not only here at St. Mary's. But I think that looking back, we were able to really manage all of that with great efficacy, and I think that I'm very happy and proud with what really all the body of physicians here at St. Mary's were able to achieve, putting all hands on deck, being on call every weekend, seeing 40, 50 patients a day, etc., whatever it was necessary. Now, of course, infectious diseases is a world of epidemics, we call it. Some of them are not that exciting to end up on TV and on papers of newspapers, etc. And maybe they don't catch the eye of general public, but there are always epidemics going on. And needless to talk about, we had the HIV epidemics 20, 30 years ago, and so we have other smaller epidemics going on. We have certain, let's say, we're in the middle of probably a syphilis epidemic, where we're having at the same time we're having an epidemic of multi-drug resistant bacteria going on, especially in hospitals and nursing facilities. So we're always in the middle of something, and of course we have to keep up to date and adjust to what really the day brings, and that's the good thing about infectious disease, because there is never a dull moment. And when I walk to the floor, anything could be coming.
Anything could be there, and that speaks to that collaboration between infectious disease and the primary team, whether it's medicine, surgical, intensive, that's working on with the patient, but really understanding those different pieces of the puzzle. And when we think about epidemics, sure, they're happening all the time, but our management of them in these mini epidemics, let's say, is very different, because you have an awareness of how to manage it, get the diagnosis. I think one of our challenges when it came to COVID-19, when we're thinking back, and I remember on the floors, there was a lot of uncertainty on how to manage it. And then as we continued to progress, and what we have now is a very strong method of diagnostics, management, treatment, prevention, and control, so that we have so we've got a better grip on it. Whereas at the beginning, none of us had that. And I remember we were, even managing it on the floors. That was where the challenge came in. The terrifying part was not knowing how to manage it.
Exactly, and that's why the main emphasis at the beginning was on prevention, on giving us time, right? We all talked about, because when we have the disease, some of the infectious diseases that we treat, they have a history of some of them 50, 60, 100, 200 years. And then there is a body of evidence. As you know, in medicine, we work with strong evidence, with randomized controlled trials is possible, with basically making sure that the interventions that we do, treatments, antibiotics, antimicrobials, they benefit the patient, they don't harm the patient. That's the point. What happens when a disease just shows up and we know nothing about it is that then we have to generate this body of evidence as we go, and that's why the emphasis was placed on prevention. Yes, don't catch COVID until we know more about COVID, and I think that hopefully some of, at least especially with the development of vaccines and development of better treatment options, etc., we are in a much better spot right now.
And that's the hope. I don't think we definitely don't want people to catch COVID. But I think we've got those issues under control. But this is where, again, when we talk about the collaboration, how does it help to continue to have that ongoing collaboration? Do we discuss interesting cases across the spectrum?
Absolutely. So, St. Mary's is not a very big hospital, so whenever there is an interesting case, pretty much everybody knows about it. So it gets discussed in residency program conferences, in other conferences among physicians, and also I would say in every corner and step wherever you get to interact with our colleagues. The way we work is really,
on the medical perspective.
Obviously,
yes.
And the way we work is as I said, we're a consulting service, so every day we're in continuous contact. Sometimes patients and families may not see this, but we're our job is not only to see them, examine them, and talk to them. We also spend significant time in the microbiology lab, with diagnostics, and similarly, we spend a significant time with talking with physicians, with all the players, the multidisciplinary team that's actually taking care of the patient, whether that is the primary medicine or surgical team or other consultants, and that's how a lot of decision making is done. So it's not just whatever I said. Obviously, nothing in medicine is like that. There is a continuous collaboration, and I think the best decisions are made that way.
Now, one of the things I've always found fascinating is when we're dealing with a patient and the infectious disease doctor says it's going to be more difficult to manage this. What's the reasoning behind that, where it becomes this diagnostic dilemma? What are the steps that end up in situations where you're getting challenged on trying to figure out what's going on?
As I said, sometimes there are diagnostic dilemmas, and that includes, of course, we in infectious disease, we love cultures, right? We love to have the name of the bacteria or a microbe that actually we know how to treat and how to target. And sometimes there are diagnostic dilemmas trying to get down to not only the name of the microbe or bacteria that's causing the disease, but also the extent of the infection, right? So on whether there are sources that need to be controlled, abscesses to be drained, things to be removed, etc. And then similarly, there are also, I think, treatment dilemmas sometimes when we see something that's rare, something that has been described. There are rare cases, but the cases that you see in literature never fit 100% the case that you have at hand.
Correct.
So you will have to make your own decisions occasionally. And I would say that with the development of social media, with the development of different ways to really contact people, I would say occasionally I would contact a world leader in a specific, let's say in fungal infections. We're not big in fungal infections in Connecticut because of the, we're big in things like Lyme disease and tick-borne illnesses.
Sure.
But for fungal infections, you have to contact somebody that's in Tyler, Texas, or in Kansas City, or somebody in Australia, or whatever. And I think the new developments in communication have made that possible. And I've contacted people that I consider to be like world authorities in these very specific rare infections, and have asked their opinion and their help for management too. So
that's beautiful to hear, to understand that we continue to make decisions from a collaborative perspective. We're not simply shooting from the hip. And when we don't know, we go out and we find the experts who do know.
Absolutely.
To give us that best track on where we need to go for the future. I think one of the greatest things I'm seeing right now, and we've talked about this a little bit, is travel. Travel's coming back. Travel has come back. I don't want to say it's coming back. It's come back. And one of the things you offer here is our travel clinic to help patients sort of navigate the challenges of some travel to some of the more, let's say, exotic destinations. And can you tell us a little bit about the travel clinic and how it
Sure. I mean, travel clinic is my favorite time. Why? Because everybody's happy there.
Yes.
Although I always tell an anecdote of a person going on a funeral trip, but generally, 99.9% of the people are happy when they travel, and that's great. People are not sick, and people are coming to you trying to prevent sickness or other bad outcome from happening. So basically what we offer here is really, I think, a 360-degree counseling and care for anybody that will travel anywhere in the world. In that, of course, there are some destinations that make patients or travelers seek counseling more. For example, I'm going to Italy next week. Probably you don't need a lot of travel counseling, but except for best pizzas or whatever.
Sure.
But there are some areas, especially as I said, Central America, the Caribbean, South America, Africa, Asia, someplace in Eastern Europe, etc., where you really need to take some measures so you can prevent basically certain infection from happening for you and your family. So what expect. We do have a specialized nurse that actually does the scheduling and counsels the patient about what to bring. We usually like them to bring their prior vaccinations and also their itinerary. Mm-hmm. The itinerary is important because there are big countries that have like very different kind of profile of infectious diseases. And then based on that, then vaccinations for certain diseases are offered, prophylactic medications are offered, and of course counseling, hopefully some important pearls for patients so they can actually fly safely, they can actually have their vacation in the safest mode possible, and then they can come back healthy. Some of the destinations, sometimes I see them underrepresented. Is probably some Caribbean destinations that people tend to feel, oh, they're like an hour away, 2 hours away, 3 hours away, but they are, similarly in like they're similar in terms of like potential for transmission of certain diseases. I'd say like places like DR, Costa Rica, and other islands that we see those patients coming less to travel clinic. That's probably this is a good platform to tell them that they need to be careful and they need to consider really getting counseling, vaccinations, and whatnot through a travel clinic as well. Patients that go to Africa, Asia, South America, etc., they tend to be a little bit more, I think, aware, and sometimes some of them, they have like prerequisites, vaccinations that they need to obtain visas or to travel or to be accepted to certain countries. Even before COVID, because people think that the COVID cards were novelty. They were not. Obviously, we've had other vaccination cards that were actually important for being accepted to other countries. One big one is yellow fever.
Yellow fever, absolutely.
And we are a certified yellow fever center as well. So basically, we not only provide the yellow fever vaccination, but also like counseling about it, etc.
Great, wonderful, good to know. So for all those taking plans to countries with yellow fever, here's your man.
Exactly.
To prevent anything from going on when you're out there. Let's talk about the future of infectious disease. What do you see on the horizon in terms of new technologies, or what can we expect from infectious disease as a medical specialty in the future?
Here at St. Mary's, I think we have an excellent group of physicians, and the Department of Infectious Disease is really, really strong. But of course, we cannot do that alone. I think that another big strength that St. Mary's has is the microbiology lab, and I think that's where a lot of like exciting technology has been, coming in the last, I would say, 5 years or so. On St. Mary's, really, we have the latest technology here for diagnostics of infectious diseases in so many levels, and we have this great staff in microlab that I think is really second to none in terms of helping on a timely fashion, because we always are racing for time. That's what infectious diseases is we want to know 12 hours early, we want to know 24 hours early, because that of course makes a big difference in the outcome. So in that regard, I think St. Mary's has multiple platforms of PCR technology for bacterial infections, for viral infections, for tuberculosis and similar infections. And similarly, I think we're acquiring what's called MALDI-TOF, TOF technology that really will enhance the identification of different microbials for as short of period as like 2 to 5 minutes, really, after a bacteria grows. So, and then together with that, of course, we are in a race with bacteria resistance versus development of new antimicrobials. And of course, there have been problems in the past. I'm talking generally globally. I think that we are probably globally behind in that fight. But similarly, we've had really some good news, some new antimicrobial being approved, and all of those medications, of course, are always available here at St. Mary's. So we make sure that we really keep an up-to-date list of things that we can offer to our patients. Similarly, as I said, we have a strong collaboration with Yale as well in terms of the Division of Infectious Diseases. We're all trained there, all 3 physicians we have right now, in different times, not together, but in different times.
In different times, yeah.
They were trained there, and so we do have a strong collaboration, both didactically, academically, and also from a patient care standpoint. Our infectious disease section is also very involved in teaching, and
Yes,
in the last several years, it's not only our residency program here, which is an excellent residency program that really serves as a great resource for the greater Waterbury area in graduating and educating physicians for the future, whether that's in medical subspecialties or as internists and primary care doctors. But similarly, we're also very involved in teaching with Quinnipiac School of Medicine and their students that come through here, or to which we give lectures, etc. And I think that also is very exciting, because as students and residents are here, they make us not only feel young, but at the same time they make us always be up to date with everything in the world of medicine. Teaching is also learning at the same time.
So it's when we think about what you're able to offer now, it's because I think about, even when we talk about PCR technology in the micro lab, how quickly we're able to understand what it is that's causing the problem for a patient from an infection perspective, which then allows you to hone in the right antibiotic, get the patient on the right treatment, all towards the goal of getting and part of their healing journey. Because what we, and you alluded to this at the very beginning, this overuse of antibiotics, or these large guns that we want to use initially when we don't know, and then by you being able to then narrow it down as quickly as you can, and by having our microbiome lab participate in that, we're really able to improve and reduce that bacterial resistance that you talked about. And so we're part of that continued fight against antibiotic resistance, which has become a big problem in the US, and something that we don't see in the rest of the world. I remember we had a family member who had an infection outside of the US, and when I was talking to the infectious disease doctor and the regular doctor there, they're like, yeah, we don't have that vancomycin resistance problem over here, because they just don't use that antibiotic as much, and yet here you're able to readjust things very quickly. So
in other parts of the world, they do have other resistant problems, obviously. I mean, there are parts of the world where antibiotics are prescribed without a prescription, and of course that has led to bigger problems. But of course, the general message for the public should be the shorter course antibiotic you can get, the narrower spectrum that really kills that specific bacteria or microbe that's causing the infection, the better it is. Anything out of that is bad. It's not only because it's not optimal, but also because it has also a lot of it will expose the patient to harm as well. And sometimes people feel that antibiotics are these benign drugs that you can take them a week more. What happens if you take the Z-Pak 5 more days, or if you take the amoxicillin another week, etc. No, bad outcomes could happen. Include side effects, include certain other infections that they can cause. Also includes resistance, which is really I think that one of the biggest problem of the future. Before COVID really started, really all our attention and emphasis was really concentrated on this multi-drug resistant bacteria, because it seems like they're really galloping really fast, and it's not it's more a question. The only thing that really makes a difference is the doses of antibiotics given. So the less antibiotics you give, the less resistance you have in the big picture. And that's true for one person, that's true for one community, that's true for one hospital and one state and one country. Is the less antibiotics you give, so the more the less resistance you are going to have. And of course, if you we're not going to stop or limit the antibiotics are really necessary,
Yep.
right? But we want to really get rid of everything that's unnecessary, whether that is through more doses, more extensive treatments, or a wider spectrum of antibiotics. That is, in general, that is bad. That's not good. My doctor gave me antibiotic just in case because I had, I was sneezing. That is actually bad. That's very bad. So that's not, oh, I'm being protected against a possible infection, etc. That is actually, I'm being exposed to the potential of serious harm.
So, and we talk about even right now, antibiotic use and antibiotic resistance as one of those measures that are actually, we're being governed and mandated to continue to work on those things from a central perspective. And I know there's a lot of work that continues to work on that, not only from an infection prevention perspective, but all the way through pharmacy, nursing, the physicians as well. So there's more to it than simply infectious disease saying stop the antibiotic. There's a lot of other background work that continues to be needed and critical.
So hospitals, including our hospital, have what we call antibiotic stewardship program. That's really has multiple players, but as you said, it includes in physicians with expertise like infectious disease physicians, the lab, IT department, and also people from pharmacy. And basically there is a continuous, not only gatekeeping, but continuous active auditing of antibiotic use, trying to really make it as optimal as possible in a hospital setting.
Pearl of wisdom for our community that's out there. And we've talked about a couple of them already, but something that you can leave for the community that's watching.
I will repeat probably some of the things that I already said, but number one is, of course, prevention. We don't want to treat infections. We don't want to really treat infections that can be prevented, right?
Yeah.
So prevention is the most important thing through prevention of exposure, immunization, etc. And then the second thing is probably, as I said, for when it comes to antibiotics, the less is better. So avoid unnecessary antibiotic treatment, and also, as I said, you can always benefit from our expertise in that regard as well.
Thank you very much, Dr. Gega, and thank you all for watching. Look forward to seeing you next time. Thank you.
Absolutely.
Have a great day.
Thank you.